Hi everyone, how are you? Welcome again to the Medical Tutor channel. Today we are going to discuss two types of STDs, or today they are calling it or referring to it as STI. STD stands for sexually transmitted disease, and STI stands for sexually transmitted infection. They are both the same thing. We are going to discuss gonorrhea and chlamydia. Those are highly encountered topics in exams and in real life, so you have to make sure that you master them. Starting with gonorrhea, gonorrhea is most tested with chlamydia, so this means that it coexists with the chlamydia in the very same time. The cause for this type of infection is called the exact cause of this infection is called Neisseria gonorrhea microorganism, and it's considered a gram-negative diplococci, and it is an intracellular pathogen, which means that it resides inside neutrophils. For the pathophysiology, this microorganism start its pathophysiology by attaching to the mucosal epithelium via villi and ovoproteins, and once it made sure that it is attached to the mucosa, it then does the invasion. And once it is inside the mucosal cell, it triggers intense neutrophilic inflammation, which means that the immune system is going to recruit more and more neutrophils to the area where the gonorrhea is attached or has already entered inside the mucosa. One of the mechanisms that this microorganism can use is producing IgA protease, which is going to degrade the IgA, causing this microorganism to evade the mucosal immunity. One of the mechanisms that is used to cause the reinfection is by doing something called antigenic variation. It is when the microorganism changes the shape of the antigen spreaded on its outer surface. So the memory cells of the immune system can't remember that this infection has entered the body previously. So the immune system has to deal with it as a new infection, which makes the reinfection very possible. The clinical features for this microorganism, since it's an STD, you are going to have clinical features in female and in male. In female, it's basically the cervicitis is the most common clinical feature, and all the other clinical features is partially or completely related to the idea of the cervicitis. Cervicitis means inflammation to the cervix. So when the cervix becomes inflamed and fragile, and it can be easily bleed. It can easily bleed upon any contact. So this is going to cause dyspareunia. This is going to cause postcoital bleeding, which is not mentioned here, and it's going to cause intermenstrual bleeding, and it's also going to cause vaginal discharge, which is mainly here purulent, which means that the color of it is yellow to green. It can also lead to dysuria. For males, the main thing is having urethritis, which is going to lead to dysuria and also the same purulent discharge that woman has. The diagnosis for this microorganism is by doing NAT. It is the gold standard. You can obtain your specimen through urine or a vaginal swab. You can also perform PCR, but it is less sensitive than NAT. NAT is the gold standard for testing for this microorganism. You can also perform a gram stain in men, and it's going to come out with intracellular diplococci. You can culture this microorganism on specific types of agar like thiamartine. For the treatment, the current treatment is giving ceftriaxone intramuscular injection as a single dose. And the problem with this microorganism is that it developed resistance for so many types of antibiotic like penicillin and fluoroquinolones. Those were used to treat this microorganism in the past, but since the microorganism developed, or since gonorrhea developed resistance against them, they are no longer used. And currently the treatment is ceftriaxone. As we said previously, gonorrhea can coexist with the chlamydia. So if you didn't rule out the chlamydia, you have to treat for it empirically by giving doxycycline. Complications in women, we are talking about something called pelvic inflammatory disease. It is abbreviated as PID, which means that when the infection goes beyond the cervix and it enters the uterine and then moves upward toward the fallopian tubes and all other parts of the genital tract, this can lead to inflammation, this can lead to adhesions, so it's going to lead to infertility, and due to adhesions it's going to lead to ectopic pregnancy. It's where the zygote is not implanted in the uterus itself, it is implanted otherwhere in the genital tract. There's something called Fitzhugh-Curtis syndrome, and is considered as complication. It's type of perihepatitis. In both women and men, it can lead to something called disseminated gonococcal infection, which is manifested as migratory polyarthritis. It means when the arthritis is started in one joint and then it moves to another joint in the body. We also have tenosynovitis as a manifestation, and dermatitis, which is going to be manifested as pustular lesions. In neonates, it can lead to type of conjunctivitis called ophthalmia neonatum, which is an acute infection that can lead to blindness if it's untreated. We are going to discuss the eye complication in neonates in further details in a coming slide. We finished gonorrhea. We are going to talk about chlamydia now. And the cause for chlamydia infection, the full name of the microorganisms, it is chlamydia trachomatis. It is considered obligate intercellular organism, which means that you will never see it in the extracellular space, unlike the gonorrhea. Gonorrhea actually is considered intercellular, but it can, in some cases, be seen in the extracellular space. And chlamydia is considered to be the most common STI worldwide, but it's asymptomatic. If he asked you what is the most common symptomatic STI worldwide, that would be gonorrhea. Clinical features, it's the same as gonorrhea, but the difference is that gonorrhea tend to be more acute infection, so the features of it are going to be more prominent. They tend to be more prominent. Unlike the chlamydia, they tend to be milder than the ones manifested in gonorrhea. It's the very same as gonorrhea. It's usually asymptomatic. It needs weeks to develop the infection. It starts as asymptomatic, and then when the infection is well established, it's going to cause cervicitis, which is going to cause all the other manifestations like postcoital bleeding, dyspareunia, intermenstrual bleeding, and the discharge, of course. In gonorrhea, we said that the discharge is purulent, which means that it's mainly composed of pus, but here it's mucopurulent, which means that it's mainly composed of mucin, added to it a small amount or some amount of pus, but the main composition for this discharge is the mucin. For men, it's the very same as gonorrhea. It's going to lead to urethritis, dysuria, and discharge. But the discharge characteristic here is different from chlamydia. It causes watery discharge, unlike the one in chlamydia, which is purulent, which means that the color of it is yellow to green. Diagnosis and the treatment. Diagnosis is very similar to the one in gonorrhea. You have to perform NAT. You can perform PCR, but it's less sensitive than NAT. So the NAT is the best standard treatment. You have to give doxycycline. It's the first line treatment unless you have like restrictions. If the patient is pregnant, you have to give azithromycin, or if this didn't work, you would give azithromycin as well. Complications of chlamydia are the very same as gonorrhea. It can lead to pelvic inflammatory disease, which leads to infertility, but here the type of infertility, it can lead to infertility and ectopic pregnancy, but here the pelvic inflammatory disease tend to be more silent, which can be considered more dangerous because when the infection is more silent, this means that it's extending inside the body without um, without the patient taking notice of it. And physicians um, can miss this or misinterpret this really easily, because they sometimes they don't pay attention to when the patient describes that she's having, for example, a discharge. They will draw their focus only on the discharge, and they will forget or ignore if she mentioned as an associated symptom to the discharge that she's having a pelvic pain or a chronic pelvic pain. Some physicians really ignore this and they don't do the analysis for it. So sometimes they miss the fact that the patient may have or may develop a pelvic inflammatory disease, aside or beside having a simple gonorrhea infection or a simple chlamydia infection. For men, it will lead to epididymitis, and in neonates, it will lead to conjunctivitis, but this is different from the one in the chlamydia, and we are going from the one. It's different from the one in gonorrhea. We are going to discuss the difference in 1 or 2 minutes, and the neonate can also develop pneumonia. We have also this syndrome, which is called reactive arthritis, and it previously was called Ritter syndrome, and they bought this mnemonic for it. They say can't see, which means the patient will develop conjunctivitis, can't be, he will develop urethritis, and can't climb a tree, which is a clear pointing to the fact that the patient have arthritis or has arthritis. When the examiner or when you see in exams this term cervical motion tenderness, this doesn't mean that the patient have a certain type of microorganism. You can't distinguish just by using this term alone. This term is a sign of upper genital tract infection, which means that the patient is developing a pelvic inflammatory disease. She has developed or is about to develop this pelvic inflammatory disease, but it doesn't distinguish between the causes. It doesn't tell you that the patient has either gonorrhea or chlamydia as a cause, as an underlying cause. This slide discusses the eye complications in a neonate in both type of infection, in chlamydia and in gonorrhea. If you want something that can help you solve the questions really easily about this topic, you are going to use this as a pivot reference, or as a pivot or as a reference, which is the neonatal timing, which means that you are going to use this when he is describing in the question that the neonate developed the conjunctivitis or the eye manifestation beyond the fifth day. This means that he is pointing toward chlamydia. If it was more acute and he developed the symptoms or features really fast, within 2 to 5 days, he's pointing toward gonorrhea, because we said previously that gonorrhea tend to be more rapid and acute than chlamydia. Chlamydia tend to be more gradual, so it's going to take more time, between 5 to 14 days, but gonorrhea is more acute, so it's going to take less time, 2 to 5 days, to develop the symptoms. For the discharge here, it's a mucopurulent, just as the discharge find in vaginal or vaginal discharge or men discharge from the urethra, and here it tend to be profuse and purulent. The severity here is mild to moderate, because we said that this tend to be mild, but this tend to be acute, so the severity is severe and destructive. The corneal involvement here is rare, but here it is common, so you have to treat this as soon as possible. They don't even wait until the patient develops symptoms. They give prophylaxis eye drops to all neonates. I don't know if this protocol applies to other countries, but from when I was in the hospital, they used to give all neonates eye drops as prophylaxis. Neonatal timing, we discussed this. Chronic disease, chlamydia can cause chronic disease as a trachoma, but gonorrhea is acute infection, and it doesn't develop chronic disease later on. Ritter syndrome, this is a more extended slide about Ritter syndrome, why it happens. It's an autoimmune condition that develops after an infection, and infection is not restricted to chlamydia. It can also develop after infections like the gastrointestinal infections, for example, Salmonella, Shigella, and Campylobacter. And the timing, it usually occurs between 1 to 4 weeks after the triggering infection. The classic triad, we discussed this before: can't see, can't be, can't climb a tree. Can't see means that the patient has conjunctivitis, which means, or which is manifested as red and irritated eyes. Can't be urethritis, manifested as dysuria and discharge. And can't climb a tree points toward arthritis, which means that the patient has painful swelling joints. And these painful swelling joints, they don't have to be symmetric. They can be usually asymmetric, and usually we are referring to the joints in the lower limbs. Other features of this disease or this complication, something called enthesitis, which means heel pain or Achilles tendon pain. Dactylitis, manifested as sausage digits. It's when your digits are swollen and they resemble the shape of sausage. Skin lesions, it's something called dermatoderma blenorgicum or something like this. Sorry, I can't really pronounce this, no matter how hard I tried. So it's some sort of skin lesion. You can search this on the internet to be more familiar with the view of it. And it can also be manifested as oral ulcers. So you have to remember those, because in some questions he's going to describe those symptoms, and you have to guess what type of arthritis the patient has. Management for this disease, which is reactive arthritis, is to treat the underlying infection. If the underlying infection is a chlamydia, you have to give antibiotics for chlamydia. You have to resolve the underlying infection so you can resolve the complication of it. If you want to manage the joint pain, you have to give your patient NSAIDs, and if the pain was very severe and the patient can't stand it and NSAIDs didn't resolve it, you can recommend steroids or DMARDs like sulfasalazine. So this is a table to summarize the differences between gonorrhea and chlamydia. Speaking of discharge, gonorrhea, as we said, it's purulent, which means that the color is yellow to green. Chlamydia is watery to mucopurulent. Symptoms here, it's more severe infection. Here, it's often silent. And even if it became symptomatic, it's going to be milder than the one in the gonorrhea. Organism, it can be intracellular and extracellular, but here it can only be intracellular. It's an obligate intracellular pathogen. Gram stain, it can appear on gram stain, especially if the specimen was taken from a man. Here it can't appear on a gram stain. Complication, acute pelvic inflammatory disease. Here it's the same complication. It's pelvic inflammatory disease, but it's silent, which means that on long term it's going to be worse, because the infection can extend and the patient can't realize it, or is not aware that there's an infection extending inside of her body. High yield information. Most common STI worldwide is chlamydia. Most symptomatic STI is gonorrhea. Most dangerous long term, which the silent form, is chlamydia. Always treat both together unless ruled out. And NAT is the gold standard for both. Pelvic inflammatory disease, you must not miss this when you are taking history. So you have to sit with yourself, make sure that you retain all the information and differences between the two types of infection, and then you come to answer the questions. I'm going to go through this one by one. You can always pause the video and think for yourself before I reveal what the right answer is. Question 1, 21-year-old woman present with dysuria, mild vaginal discharge. She also reports postcoital bleeding. On exam, the cervix is friable and bleeds easily. She is sexually active with a new partner. What is the most likely diagnosis? So he told you that the patient is having postcoital bleeding and the cervix is friable and bleeds easily. So when he is describing something like this, you can choose either gonorrhea or chlamydia. He's not going to provide those two answers in one question because you can't differentiate between them just based on this description alone. He has to give you more clues so you can differentiate between them. But you have to think that it's going to be either one of those two infection. So you are going to rule out all the other causes like candidiasis, vaginosis, genital herpes, and trichomoniasis. You are going to be left with chlamydia trachomatis infection. Here, there is nothing to point out candidiasis or vaginosis or herpes or trichomoniasis. These manifestations are really related and clearly related to STI like chlamydia or gonorrhea. Question two, 23-year-old woman is diagnosed with gonorrhea. So he gave you the diagnosis. He is just asking you what is the treatment. So you have to memorize the treatment for gonorrhea. It's ceftriaxone, and you always have to treat for chlamydia if you didn't exclude it by giving doxycycline because they coexist with each other, gonorrhea and chlamydia. Question three, 26-year-old woman present with vaginal itching and discharge for 5 days. She recently started a new sexual relationship. Okay. Exam shows erythematous vaginal mucosa and thick white discharge. Vaginal pH is 5.2. Using the pH as we did in the previous video, you are going to exclude directly candidiasis because candidiasis does not have elevated pH. It has to be within the normal limits, which means the numeric value of it has to be 4.5 or less. So because you have an elevated pH, you are going to think of things like bacterial vaginosis, trichomoniasis, or other things. Wet mount is negative for motile organism and KOH prep is inconclusive. What is the most appropriate next step? Treat with fluconazole. We already ruled out candidiasis. Treat with metronidazole. We are not sure that this is bacterial vaginosis or trichomoniasis because here it says that the wet mount was negative for motile organisms, so it's not trichomoniasis, and you can't make sure you can't be sure that it's bacterial vaginosis as well. You didn't test for it to make sure. Perform NAT testing for STI or reassure and repeat. No, you can't do this one. Start acyclovir. This is given for herpes simplex virus infection, and it's not manifested here, so we can't also do this. So either you are going to treat with metronidazole or perform NAT testing for STI. Well, the right answer is to perform NAT testing for STI. This is an MBME style question, and the writer for this question, they don't like you to jump into conclusions and to assume that the cause is bacterial vaginosis, for example, and to treat directly. You have to make sure what you are dealing with. So you have to do the NAT testing and make sure that you don't have STI, and then you can safely assume that it's bacterial vaginosis and you can treat accordingly. So the right answer is to perform the NAT testing. Question 4, 22-year-old woman present with dysuria and vaginal discharge. She was treated for a UTI 1 week ago, but the symptoms persist. She now reports pain with intercourse. Exam shows cervical motion tenderness and mucopurulent discharge. Which of the following complication is she most at risk for? He's describing here a patient that was treated for UTI, but her symptom persists. It's because vaginal infection has vaginal infections actually have urinary manifestations. So if you assumed that the cause for the patient symptom is urinary and you didn't treat the vaginal infection, the underlying cause is still there. You have to resolve the vaginal infection so the patient can resolve her so you can resolve her urinary symptoms like UTI. Now she is having more and more manifestations toward STI like dyspareunia, like cervical motion tenderness, mucopurulent discharge. So what is the complication for this? The complication is infertility. It's BID, pelvic inflammatory disease, infertility, or ectopic pregnancy. So if he mentioned pelvic inflammatory disease, infertility, or ectopic pregnancy, you are going to choose that. Looking for other choices like valvular carcinoma, toxic shock syndrome, endometriosis, and ovarian torsion, they are not related to this condition. Question 5, 19-year-old woman present with vaginal discharge and itching. Whit mount shows numerous white BCs, but no organism are visualized. The pH is normal. Which of the following is most likely diagnosis? Since the vaginal pH is normal, you are going to exclude trichomoniasis and vaginosis because the pH in those infections tend to be high or elevated, not normal. So you are left with candidiasis, genital herpes. He's not here describing genital herpes. He's not describing any ulcerative lesion or vesicular lesions. So you are going to omit this as well. You are left with either chlamydia trachomatis or vulvovaginal candidiasis. So here it tells you that the wet mount shows white BC, but no microorganism are visualized. If it's candidiasis, you are going to see hyphae or pseudo hyphae if you added KOH to the specimen. So since you can't see something like this, you can't say that it's vulvovaginal candidiasis. It has to be chlamydia trachomatis infection because it's an obligate intercellular pathogen, and that's why you didn't visualize anything upon testing under microscope, but you still have white BCs, which assures you that there's an infection, but you can't see the microorganism because it's intracellular. The right answer would be chlamydia trachomatis infection. Don't just fill for the fact that he mentioned itching. Don't just assume it's candidiasis because he mentioned that the patient is suffering from itching. Just be careful. Okay, question 6 is telling you that the patient has postcoital bleeding and the NAT confirms gonorrhea. Which of the following is the primary mechanism of the tissue damage? How did the gonorrhea cause the tissue damage in this case? Is it exotoxin production? Is it direct viral cytotoxicity, host inflammatory response, immune complex deposition, or fungal invasion? Fungal invasion and direct viral cytotoxicity can be easily excluded because we are talking about a bacteria here, not about a viral or fungus infection. So you are left with A, C, or D. We didn't, when we discussed the pathophysiology of gonorrhea, we didn't mention that it can cause immune complex deposition, so you can omit this as well. And we didn't mention any kind of exotoxin. What we mentioned is that it causes neutrophilic inflammation and recruitment of neutrophils. So the damage is mainly caused by host inflammatory response by recruiting those neutrophils. When they come to the scene, they are going to release enzymes over gonorrhea, trying to degrade it, and these enzymes are going to get on the surrounding tissue and cause the damage or the cervicitis. Question 7, 19-year-old man present with dysuria and purulent urethral discharge. Gram stain shows intracellular negative diplococci. So he's telling you that this man has gonorrhea because it's purulent, it's a gram-negative diplococci. Which virulence factor allows this organism to evade the host immunity? How can gonorrhea evade the host immunity? Is it by using capsule or antigenic variation of the villi, or spore formation, or endotoxin neutralization, or biofilm? We didn't mention anything about endotoxin or biofilm or spore or capsule. What we mentioned is this mechanism. It's called antigenic variation of the villi. It changes the shape of the villi, so the memory cells of the immune system can't recognize that this microorganism has entered the body previously. It treats it as a new microorganism. And it doesn't have a cascade to how to deal with this microorganism, and like initiating this cascade takes a lot of time. It takes a lot of time to for the immune system to learn how to deal with such a microorganism. If it changed how it looked and the memory cell couldn't recognize it. Question 8, a 24-year-old woman presents with fever, lower abdominal pain, and vaginal discharge. Okay. I guess we are suspecting a BID because those are the symptoms for BID. It's pain, fever, and vaginal discharge, and she has cervical motion tenderness. As we said previously, this points out toward BID, but it doesn't tell you what the underlying microorganism is. Which of the following is the most appropriate initial management? Is it a wait for culture results before treatment, or treat with doxycycline alone, or start ceftriaxone, doxycycline immediately, treat only if symptoms worsen, or perform hysterectomy? Well, actually, the right choice is to start ceftriaxone and doxycycline immediately, because pelvic inflammatory disease is a clinical diagnosis. You don't have to wait for the culture results before you treat. You can treat and then you can see what the results came with. Question 9. A newborn develops conjunctivitis 3 days after birth. The mother had no prenatal care. Which microorganism is most likely responsible? Yes, we said that in those cases, when he asks you about conjunctivitis, you are going to rely on the time. If it's before 5 days, think gonorrhea. If it's beyond 5 days, you have to think chlamydia. So we have 3 days, which is within 5 days period. We are going to directly think about Neisseria gonorrhea. Question 10. A patient was treated for gonorrhea with ceftriaxone. 1 week later, symptoms persist. What is the most likely explanation? Well, is it antibiotic resistance? Is it reinfection from untreated partner, viral co-infection, autoimmune, or incorrect diagnosis? That would be reinfection from untreated partner, because this is an STI. You have to treat the partner. If you didn't, then the symptom will recur. Question 11. 22-year-old woman present with fever and joint pain for 4 days, reports pain that started in her wrist and moved to her knees and ankle. She is sexually active with multiple partners. Here he is describing when he said that the pain started in her wrist and moved to her knee and ankle. He is describing migratory polyarthritis. She also has fever. She also has pain along tendon sheath of the hand, which means tenosynovitis, and she has small pustular lesions in her palms, which is all those tenosynovitis, migratory arthritis, and pustular lesion or skin lesion manifested as pustular lesions. They all point toward disseminated gonococcal infection. And also, when they did analysis from the knee, it showed YTBC higher than 50,000, and the gram stain was negative. Which of the following is the most likely diagnosis? It's disseminated gonococcal infection. In disseminated gonococcal infection, the fluid analysis from the joint, the YTBC count tend to be above or around 50,000. So pay attention to this. Question 12. A man presents with right knee pain and swelling. Okay, arthritis here. We have mild eye redness and dysuria. Can't climb a tree, can't see, can't pee. It's pointing toward reactive arthritis. It is a complication for chlamydia. 2 weeks ago, he had unprotected sexual intercourse. As we said, it takes time between 1 to 4 weeks to develop. So he has 2 weeks. He developed or not. Well, he actually has the unprotected sexual intercourse before 2 weeks, and then after 2 weeks he developed these symptoms. So he is within the time frame for developing reactive arthritis from a chlamydial infection. Upon exam, there is a fever, there is an arthritis, there is conjunctivitis, but there's something else actually. There is a skin lesion manifested as pustular lesions on the trunk. So this changes the equation completely. When he described that he's having a pustular lesion, you have to think toward gonorrhea. You have to think toward disseminated gonococcal infection, because reactive arthritis can cause a skin manifestation, but it's not, it can't manifest as pustular lesions. So this is associated more with the disseminated gonococcal infection. And as we said previously, gonorrhea can coexist with the chlamydia. So he might be having those symptoms due to his chlamydial infection, but the main infection is gonorrhea here. And the synovial fluid analysis, when they drew the fluid and they analyzed it, the white BC is 48,000, which is around 50,000, and the gram stain is negative, which is the most likely diagnosis. This would be disseminated gonococcal infection due to the pustular lesion and the count of white BC, but mainly due to the pustular lesion. Question 13, a 25-year-old man presents with left ankle pain and swelling, and he had diarrhea 3 weeks ago. He now reports eye redness and painful urination. Okay, can't see, can't be. And here is arthritis, which means can't climb a tree. And we said that reactive arthritis doesn't only have to develop after chlamydial infection. It can develop after gastrointestinal infection, and usually gastrointestinal infection manifests as diarrhea. So we are describing a reactive arthritis here. And the joint aspiration, the white BCs were 12,000, which is far less than 50,000, which is found in gonorrhea. So we are talking about chlamydial infection, and the type of arthritis related to chlamydial infection is reactive arthritis. 10-day-old infant present with eye redness and watery discharge that became mucopurulent. The baby is otherwise stable, which is the most likely diagnosis. We said in questions talking about conjunctivitis, you are going to rely on the timing of symptoms. He developed these symptoms after 10 days, which is beyond 5 days, which means it's chlamydial infection, not gonorrheal one. There is something else that can point toward the chlamydia. It's the watery discharge that then developed to become mucopurulent. If it's gonorrhea, it has to be purulent. It can't be mucopurulent. So the diagnosis is chlamydia trachomatis infection. And with this, we finished our lecture. I hope you like it, and I hope you enjoyed from everything we discussed. You can write in the comment if you want me to explain something else. I'm also going to attach my email in the description box if you want to benefit from more tutoring, medical tutoring services. You can always write to me on that email, and see you again.